I'm here now. All right, so I just want to thank everyone again for joining us. It's hard to believe this is our 14th webinar in this Learning Network series for the AHRQ Pressure Ulcer Prevention Program Initiative. So thank you all for joining. We're happy to have you here today joining us with Dr. Karen Zulkowski, one of our standing expert faculty on this project. And we listened to the different challenges and topics that you were interested in, and this topic on device-related pressure ulcer is being provided to you specifically because of your requests in the past. So we hope that you find the information valuable and that you ask any questions that you have. So, but before we get started, let's just go over a few things. We'll quickly do the housekeeping stuff like we normally do. And then I want to just say a couple of things about our upcoming webinar topics, and then we'll go right into having Karen share the information that she has for us today. And then hopefully we'll have a good 20 minutes or so for questions and discussion, questions that, perhaps we might ask you, or questions that you want to ask Karen, Dr. Zulkowski. And then we'll wrap up. So just as a reminder, today, because we have Karen doing her presentation to start with, we have everybody put on mute. So you'll see that the little red X next to your name. So when we get to the discussion point, please make sure to use the hand feature or the chat feature to let us know if you have a question that you want to ask so that we can unmute you. And again, try to keep the volume in the background to a minimum, and you can do that by muting your phone, and then, like I say, just unmuting yourself when you have a question to ask. So in terms of our upcoming webinars, we have a special presentation next month as well, just like this month. We're going to be hearing from an outside expert. Her name is Dr. Pat Poza, and she's going to be talking on the topic of sustainment of quality improvement initiatives. And just to note, we're actually inviting all of the falls prevention hospitals to join us for that particular webinar. So we'll have a larger group of individuals on that webinar, and it will occur on the same day and same time next month. And then in November, Dr. Zulkowski will be joining us again to talk about measurement and how to use measurement, your pressure ulcer measurement data to actually tell a story. So we hope that you'll join us for that webinar as well. So with that, I'm going to pass the presenter ball over to Dr. Zulkowski, who is going to lead the discussion today. Karen,
thank you.
I've just given you the ball, so go ahead.
Thank you very much. So that was my dogs you were hearing in the background who were having a discussion about breakfast, and they're feeling cute this morning. I'm in Hawaii, so it's only 7 a.m. here, so you'll probably hear the roosters outside that are running around and a few other things. Just know that I'm sitting out on my lanai because that's where I get the best cell phone and computer Wi-Fi coverage for some odd reason. So I'm going to talk about medical device-related pressure injury. And one of the things with medical devices is that we've always seen wounds from it, but we've never really thought about the implications of it and the fact that pressure, moisture, friction, shear, how they work with devices to cause injury to the skin. It's really impossible to talk about anything without looking at moisture, friction, shear all together in terms of causing injury. And you've got to think about all those things when you're looking at medical device-related injury. So I'm retired from Montana State University. I got tired of playing politics at a university and decided to retire and raise coffee in Hawaii, which is what I'm doing. It's been a learning experience. But I still am active in doing wound care, and I'm the journal editor for the World Council of Interstomal Therapists, and I'm on their board. And I'm a former NPUAP member, and I am the representative from WCT back to it. I also am on the editorial board of Ostomy Wound Management and Advances in Skin and Wound Care, and I consult with several nursing homes on different skin issues. So today we're going to talk about what are medical device-related pressure ulcers or pressure injuries, and what is a mucosal injury and how does it differ, and how do you prevent it, and what should you document. And you know, documentation is so important in everything you do. This morning I got up really early. One of the things I had talked to a nursing home that I consult with yesterday, late yesterday, and they needed to get me some medical records. The state had come in and, well, the daughter had caused an issue. Her 92-year-old mother went from the nursing home to the hospital, and 2 days after admission to the hospital, they documented that she had a stage 2 pressure injury on her coccyx. Now, the daughter called the state and complained that it was the nursing home's fault. Her mother had failure to thrive, was late-stage Alzheimer's, wasn't eating, was combative, was on long-term prednisone, a lot of skin tears. And so the state surveyor wanted to cite the nursing home. But in this case, there's no evidence that the nursing home was where the pressure injury developed. Undoubtedly, it was the time between, and you can't tell me 48 hours later in the hospital, the first they documented, you can blame the nursing home. This blaming each other has kind of got to stop, but the documentation has got to be better and very specific. In other words, the nursing home should have been more specific in saying there was no pressure injury when this person left. Her skin, besides the skin tears that she came in with that were not completely healed, there was no sign of a pressure injury on her coccyx. So this documentation, be it on your coccyx or on your face or the back of your head, is critical. I had one lawsuit that I reviewed the medical records for a little boy that developed a very large wound in the back of his head from having a trace. And he ended up having to have skin grafts, and and this was after the child had had multiple other surgeries. So it can be pretty debilitating if we don't look for these medical device-related pressure ulcers. So NPUAP is now talking about pressure injury rather than pressure ulcer. And most government forms, government agencies haven't really recognized this change yet. Frankly, if you don't document it as pressure injury, you still use pressure ulcer or vice versa. That's not the important point. The important thing is that you document the size, characteristics, et cetera, of the wound. When it developed, what you were doing to prevent it, how you're treating it, who was notified, education provided to the family and patient. Those are the things that are really critical, regardless of what you're calling any wound. And so a pressure injury is localized damage to the skin and or underlying soft tissue, usually over a bony prominence or related to a medical or other device. And this is now in the definition. The injury can present as intact skin or an open ulcer and can be painful. The injury occurs as a result of intense or prolonged pressure or pressure in combination with shear. The tolerance of soft tissue for pressure and shear may also be affected by microclimate, nutrition, perfusion, comorbidities, and condition of the soft tissue. So if we think back to this lady who was actively dying and only lived a week in the hospital, you can understand that her skin didn't take much for a pressure ulcer to develop. If you think of medical device-related pressure injuries, Think of the lady laying on her Foley catheter tubing, for example. If she couldn't respond and move herself to get off it or shift her weight, just laying on that tubing can cause an injury. A medical device-related pressure injury is an etiology. It results from the use of devices designed and applied for diagnostic or therapeutic purposes, and these are staged. The resulting pressure injury generally conforms to the pattern or shape of the device, and you use the regular staging system. Now, you need to think about the fact that around your face, around your ears, your skin is very thin, and so it doesn't take as much for an injury there to develop. This is a little different than pressure injury that develops in the mucosal membranes. We've all seen them around the nose from oxygen. Normally, these are found only, primarily around the face, but any tissue that's mucosal can be damaged, but these are not staged. And it's mainly because your mucous membranes are so thin that it doesn't take as much for this to immediately be full thickness. And because they're usually so small, it's not something that you can really stage. But all of these develop in most settings. 8.1% of tracheostomy-dependent children, 8.6% of neonatal intensive care babies in Japan, and 34.5% of facility-acquired pressure injuries in the United States were identified as medical device-related. So both types of injury are very prevalent in both populations. I keep throwing things at them, but it's not doing much good. Because of this type of injury is a newly identified issue. Hold on 1 second, please.
No problem.
I'll let you guys out. You're not coming back yet. They seem to know when I'm on the phone, so I kick them all out. Okay, so because it's fairly new, it's not often identified accurately, so it's really hard to get a handle on exactly what the prevalence and incidence of this type of injury is. Obviously, devices can increase pressure, not over a bony prominence. And this is actually a picture of someone that I took that laid on her catheter tubing, and that's how that developed. And often the patients developed edema. You know, these people aren't well or they would be moving themselves. The device can be made of rigid material that's contributing to pressure in an odd spot. It can be misplaced, like in the case of this catheter tubing, or secured too tightly. And that can be anything from compression stockings, casting, neck braces, Foley catheter securement devices. Or it could be because it's not the correct size, or from the time the patient got the device till now, their size has changed. Examples are catheter tubing, leg straps, elastic straps on O2 masks, or some of the compression stockings or boots that become twisted. And the straps, even, you know, you're trying to protect the person's heel, they move around, that boot turns, and the straps can end up causing pressure injury. There's also the element of friction between the medical device and the skin. There's also perspiration. You know, and depending on where you live in the country, this can be significant. The difference between when it's, you know, 20 below zero in Montana and it's always 83 here in Hawaii is the amount of perspiration. And different parts of your body have different flora and fauna and are more wet anyhow. So the tubing in these areas, if you add things like incontinence to the mix or wound exudate, are going to really cause a lot more moisture damage, and friction's not going to take as much to cause an injury. And often the devices are found in areas of limited adipose tissue, like your face. It can be very difficult to see under the device because it has been secured or is tight. You know, you don't want to go in and wake the patient up if they're in intensive care and they have O2 on just to check their skin. But the injury can be much more severe, such as a stage 3 or 4, before it's even noticed. And it might not take very long for that to occur. So think about our old lady that I was talking about this morning. She's been taking prednisone. If we put an oxygen mask on her very tightly, it would not take much for us to start breaking down the skin of her face or around her ears. So catheter straps, again, oxygen masks, cervical collars, trach sites. Both the device and how it's secured can contribute to the problem. If you look at the picture of the catheter tubing just using tape, it's going to pull on the skin and that's not going to move much. Or think about the picture on your left. How's that secured, and is it sweating underneath that, that covering dressing? Ask yourself and get your staff to recognize, does the device contain hard plastic, metal, etc.? Is this something that can increase friction and shear? Is edema present in the area? You know, and sometimes edema can be in odd areas simply because the person's lying down and it's postural dependent. So can this device be even more destructive to the tissue? If we're using tape, how's that going to affect the skin? And can we potentially cause a skin tear? Or do we have a strap or something secured too tightly that it's actually contributing to the pressure? Can you look at the skin under the device? How long is this going to stay in place? In other words, are they going to have oxygen or the trach? Is it going to be a long-term versus short-term? Because the longer they have it, the more likely they are to develop a problem if we're not vigilant. And how do we remove the device? In other words, if we're pulling that tape off every single day, what's that going to do to the skin? If it gets wet around the trach site constantly, how's that going to affect the skin? So always keep in mind potential complications when we're using any kind of medical device. And as we've become more aware of this issue, it's become more critical than ever to document. Think about the type of device that you're using and the location of it. How is the device secured? What's the condition of the skin under the device? And what prevention practices are you using? You know, we've long been aware that we needed to keep everything clean. We secure the Foley tubing so that it's not pulling. We talk about changing dressings around trachs and feeding tubes, and we look at all these different things, but we haven't really thought about their impact on the skin, and we haven't done more than document what we've been required to do. So now we're telling you to include this in your skin assessment, to really look at around tubing, to look around medical devices, to look at those boots and casts and support stockings, and see what effect this is having on the skin, and document that you've checked. Because if it's not there, and your facility calls me and says, hey, you know, we have an issue, we need you to review these medical records. If it's not there, I can't say whether you did it or not. There's been some research done on medical device-related pressure injury, and this was done in intensive care. And ICU patients were followed for 7 days. There were 485 people in the study, and about 3% developed medical device-related injury, with endotracheal and NG tubes being the most common. Now, obviously, people in intensive care are very ill, but even 3% is going to delay their healing. And remember, these people being very ill are much more at risk for developing an infection. And Joyce Black and her colleagues looked at medical device-related pressure ulcers in hospitalized patients. And this was a secondary analysis of existing medical data. We had a little over 2,000 people. And 5.4% of the pressure injuries were facility acquired. And of these, this 5.5%, 34.5% were device-related injuries. So a large percentage of the pressure ulcers actually were related to the medical devices. That's a lot. It more than doubled in these people with any medical devices. So if you have a medical device, you're much more likely to develop any kind of a pressure injury. In this one, it was looking at using data to guide statewide changes, and this was 225 people. Hospital-acquired stage 3, 4, or unstageable were what they were looking at, and 29% of those acquired in the hospital were medical device related. So you're seeing, 30 to 35% of the hospital acquired being related to medical devices. And while we don't have a lot of data on it yet, even thinking that a third could possibly be related to medical devices is way more than we should have. This was looking at people using nasal oral versus full face ventilation masks, and they compared two groups of 100 patients each. And the nasal oral mask, 20% developed some kind of an injury versus 2% of the full face mask. We need to think about people that have more than one device. And obviously these people are sicker, and the sicker you are and the more comorbidities, the more at risk for any kind of skin injury you have. Not only pressure related, but medical device related, venous stasis, edema, lymphedema, skin tears. These people frequently depend on their devices for survival, for example, a trach. There's been prolonged use of devices. There can be localized tissue edema at the site of the device. Frequently, people have poor tissue oxygenation, which makes them much more susceptible to the effects of pressure, friction, shear. They have peripheral vascular issues. Anyone that has any circulatory issues that have been noted as arterial or venous ulcers, or that has required them to have a CABG, heart surgery, for example. If they have large vessel issues, they're going to have micro issues in their skin as well. And so that's going to really impact how much oxygen and nutrition the skin is getting and make them much more susceptible. Often there's an altered metabolic rate and decreased nutrition, and this is why having a nutritional consult is so important. Because we're giving them Ensure doesn't mean they're actually getting the nutrition from the Ensure, and you've got to work with your registered dietitian, have her help with what they need to help force them to get some nutrition being metabolized. They often have decreased sensory perception or a limited ability to respond to discomfort. I've said before, you feel the need to shift your body weight every 15 minutes, even in your sleep. You're moving around, your body tells you. But some of our elderly, people that maybe we've medicated heavily, people that have limited ability to move themselves around, are not moving off these devices. So devices that are intended to prolong their life and be helpful are actually causing issues with their skin. You need to think about what's being used. And I know one of the questions was, how tight should that oxygen be? Well, the answer is, remember, you're only using so much of the oxygen that you breathe in. You don't need this mask so tight that it's completely occluding any of the outside air. The idea is to have it tight enough that it doesn't slip off, but not so tight that it's causing redness of the skin underneath it. You don't want lines to form on the face, and you want to look and see if this is happening, especially in people that have edema. A nasal cannula can twist and obviously dry the mucosal membranes, and we've all seen this happening. And we all see the little old people or even younger people who have been twisting around, and the oxygen is now someplace other than where it should be. Catheters should not stay under the leg, and that strap should not be too tight, but there should be a strap. Neck braces, trach tubes, and feeding tubes should be checked. And don't forget about our back therapy tubing. You know, backs work really well for wounds. Negative pressure really has revolutionized healing in a lot of these really huge wounds. But if we aren't careful with where those tubes are, we get the patient completely tangled up in everything, or they're laying on it. And that is a fairly rigid plastic tubing. Think of all the people that they put neck braces on the way to the hospital, and think about the fact that they could have some injury to their skin just from the transportation and wearing that, especially our older adults. If you look at this picture in the bottom left, that's the person that you were seeing that has the mask on. She's actually an ICU nurse, and we used her in a little video we were doing and put the oxygen on her. And in 15 minutes, by putting that on very tight, you can see she has redness on her face. Now, Pam is healthy. She's the supervisor for the ICU in one of the hospitals in Montana. But her skin actually started showing the effects of that strap that quickly. That's why it's so critical that you move the strap or tubing frequently. You can pad under the area, either by padding the tubing or using a dressing, and they're now making some padded dressings that actually are small that can go under some of this tubing. Don't forget to look at the bridge of the nose. The skin is extremely thin. Make sure your facility has procedures and documentation of these areas in place. In other words, look at that procedure book. You really need to use it, and you need to be able to show that your facility is aware of this as an issue and what they are doing. It also then gives you a standard to go back and look at. The next time I'm going to talk about bringing the measurements down and what they mean to you. But one of the things is going back to that root cause analysis lecture also and looking at factors that can contribute. And if one of the things is that you have the policy and procedure in place, but you go back and do a random selection of charts of people that have any kind of medical device-related injury and you find it's not being carried out, then you know where the problem is. So know that you have the policies and procedures, what the documentation should look like, and then see if it's being done. Provide both the patient and family education on the devices used. The more we can tell the family, and if the patient is able to be taught the patient, what we're doing and why we're doing it and why they need to tell us if they're feeling any pain or it's starting to feel irritating to them, or they feel like it's wet because they're perspiring so much or have drainage on it. The more we involve them in their care, the better our care is, and the less likely we are to end up with a lawsuit because they say nobody told me and I didn't understand. In your toolkit, there actually was a whole thing on different things you can do for the Braden scale scores. And so we talked about types of devices associated with pressure ulcers way back then. We knew they occurred, we just didn't give it a lot of emphasis. So I want to point out that you do have this. Remember, because of neuropathy and because of heavily medicating patients, they can't always feel pain. For cervical collars, make sure it's the correct fit and placement. Check the frequency of use order. In other words, can we take it off for a while, or does it have to constantly be on? We need to remove cervical collars, not only to clean, but to check around them at least every 8 to 12 hours. And depending on the person, that might be a lot more frequently. If we're going in and looking at their skin, make sure you take the time to inspect the medical devices. If they're removable, change the inner pads and wash every 24 hours or more as needed. Sometimes these get really wet. And make sure that everyone knows that includes if they just spill water on themselves. Educate the staff on proper placements, as well as the patient and family. We need to talk to them about discharge care, positioning, cleaning, turning, and repositioning if this person is going home. But we also want them to have that knowledge if they're going to another facility, so they can make sure these things are being done in the next facility as well as yours, which does have the knowledge. If the patient comes in on a backboard, remove them from the backboard as soon as possible. We found people that had a cumulative time of 60 minutes or more on a backboard were much more likely to have a pressure ulcer once they were admitted into the hospital. In other words, there's a direct association with being on a backboard too long and having a pressure ulcer. Educate the staff on backboard removal and educate the family on discharge care, positioning, cleaning, turning, and repositioning. You know, and this doesn't matter where you are in the United States. In Montana, we had very long transportation times from the rural areas to one of the major hospitals in the state. So when I lived in Red Lodge, it could have been well over 60 minutes just in the ambulance, not counting the stop first from my house to the hospital in Red Lodge and then from there being transported to Billings. So I probably would have been on a backboard for a couple of hours. Here in Hawaii, on the Big Island, all the major medical care is in Honolulu. So oftentimes people are transported to Honolulu. So you have really long transportation times. It's the same in any of the states where you're going from a rural area to a major area for medical care. So keep that in mind. Backboards and skin don't mix for a long period of time. Nasal cannulas, check the skin under and around at least every 8 to 12 hours or any time you're going in to look at the oxygen setting. Document the skin condition and educate the staff on prevention and documentation. Again, include the family. Tray care provides site care that includes skin assessment every 8 to 12 hours or more if the patient is coughing and you're suctioning and they have a lot of secretions. Educate the patient and family. Endotracheal tubes, check the skin under the straps and around the ET tubes every 2 hours. Check position and rotate every 2 hours, right, left, middle. Educate the family and patient and make sure they understand that you are moving them. NPUAP on their website has some free information that you can download from this website. And they also have a poster that's available. NDNQI has some training material about medical device-related pressure ulcers, and all of these have some really good examples of what you can show people and what you can use. And I know you probably have some questions since this is a fairly new area, so I'm going to open it up for discussion.